Hello, everyone, and welcome to the second day of the Best of ASCO Africa, in which we continue the discussion around all things oncology. On this second day, specifically in the breast cancer series, we're hoping to share with you a couple of abstracts that we feel are incredibly relevant to our practice on the continent. My name is Miriam Mutebi, and I'm a breast surgical oncologist at the Aga Khan University Hospital, Nairobi, Kenya. And today I'm going to be sharing with you the results of a highly anticipated randomized phase 3 trial of the value of early local therapy for the intact primary tumor in patients with metastatic breast cancer. This is a study done by the ECOG-ACRIN group. Collaboration, as you know, has been responsible for seminal work like the Taylor-X study. But in this particular 2108 study, Dr. Khan and colleagues are looking at the question of what is the benefit of local regional therapy in de novo metastatic breast cancer. And this is, of course, an incredibly relevant question to us because, as we know globally, about 60% of newly diagnosed breast cancer patients present with stage 4 disease. And in low and middle income countries, this actually ranges anywhere between 10 to 20% of all patients at diagnosis. And one can perhaps see the appeal for local regional therapy because the supposition is that it may perhaps improve the quality of life. There's been the theory around perhaps having new seeding. Does a primary act as a focus for new seeding and potentially affect progression-free survival of patients? And looking at as well, would early surgery prevent worsening disease downstream? And the body of evidence, I would say, especially around retrospective studies, has been differing because, and of course, there is a bit of selection bias in the sense that quite a number of these patients were much younger, had smaller tumors, and overall a lower metastatic burden. And this has to be contrasted with the questions around, cost of care and what is the best overall outcome for these patients. And a couple of recent studies, I would say data from India, the Tata Memorial Study in 2017, probably is a closer population profile to us, more advanced disease, larger burdens, who received systemic therapy and then subsequently had early local regional therapy, but they were not able to demonstrate any overall survival benefit for either local regional therapy or no. And of course, the critique was that perhaps, again, quite a significant number of their patients were not able, especially the HER2 positive patients, were not actually able to get their care. And this is contrasted with the data from Turkey, where, and surprisingly enough, they were able to demonstrate at 5 years an overall survival difference of about 17%. However, the critique behind the Turkish study was that they were randomizing patients ab initio, and so you were not necessarily able to tell or weed out the patients who were progressing on who were having disease progression. And the other thing is it didn't really consider the different subtypes of breast cancers. And so the E2108 study tried to get patients de novo, have them go through systemic therapy for a couple of months, and then when they didn't show any evidence of disease progression, subsequently randomized them to either continue systemic therapy or early local therapy with a follow-up for about 5 years. And local therapy involving either tumor resection and post-operative radiotherapy as per standard of care. And so with the primary endpoints looking at what was the overall survival, did it actually make a difference? And keep in mind, doing a deeper dive into the time to local regional progression, but also incredibly important for patients who are dealing with metastatic disease, what was the health-related quality of life of these patients, along with looking at absolute value of circulating tumor burden cells and the collection of biological specimens. And so out of the gate, they had about 390 patients, so they subsequently randomized about 65% of them. 2 arms, about 130 had systemic therapy, and 125 had local therapy, with an overall crossover rate of about 14%, slightly lower than what was anticipated of about 15%. And looking at the patient population, the majority of patients were postmenopausal, with, unsurprisingly, the majority of patients having hormone positive HER2 negative disease. In terms of metastatic sites, quite a number of patients had combined both bone and visceral mets, and quite a number of, with about anywhere between 27 to about 30% of patients having only skeletal metastases. And with the majority of patients, which again was a critique of the Tata Memorial study, with the majority of patients receiving any of patients who required HER2 positive treatments, majority of patients received HER2 targeted therapies. And so in looking at the patient profile, unsurprisingly, given the location of the study, the majority of the population was heavily European, with about 15 to 16% patients of African ancestry in both arms. And out of the 125, 109 received surgery, and about 87 of those were able to have surgically freed margins, and 74% of patients received local regional radiotherapy. And what were the results? We were interested to find that there was no improvement in the overall survival. The median follow-up was about 54 months, and the median follow-up was about 53 months with a median survival of 54 months. And what they were able to demonstrate was in both arms, irrespective of therapies, there was no improvement in the overall survival. Interestingly enough, there was also no improvement in the progression-free survival. Keep in mind the hypothesis that, you know, maybe having the primary would somehow worsen disease or the pre-existing condition. And although it was a small subset, they were actually able to show that there were worse outcomes, overall survival, especially for patients who had triple negative breast cancers. And so in terms of defining the local regional progression, what we were able to see in the continued systemic therapy, there was development of symptoms leading to a decision for local therapy, and with the early local regional therapy that was defined as regional nodal progression or chest wall disease or invasive in-breast recurrence. But what was noted was the occurrence of distant progression did not preclude the reporting of later local regional recurrence or progression. And so another critical aspect was looking at the overall quality of life at different time points. And they used the FACT-B trial outcome index. And what they were trying to look at was what was the overall quality of life at both at 6 months, 18 months, and 30 months. And again, no overall significant difference was found between arms at either assessment time points. And one would perhaps hypothesize that, you know, the surgery or radiotherapy would give an overall better quality of life, but perhaps this was contrasted with the subsequent potential complications or adverse effects that patients had as a result of their care. And so in conclusion, we would say that early local therapy does not improve survival in patients with de novo metastatic breast cancer and an intact tumor. And although the authors saw a 2.4-fold higher risk of local disease progression without local regional therapy, this, however, did not lead to an improved health-related quality of life. And I think based on the available data, then one should not necessarily offer primary local regional therapy for women who have stage 4 disease with the anticipation of somehow altering the overall outcome. And where systemic disease is well controlled, but we're still having local progression, for sure we do need to consider local regional therapy. Again, just to put in a teaser, the results from the JCOJ 1017 are pending, and perhaps this will also contribute to the body of evidence around how to manage our metastatic breast cancers. What does this mean for our practice on the continent? One, the challenge has been sometimes that as surgeons, we're a little scalpel happy and we see the patient come in even without staging, they blink and somehow they find themselves on the OR table. And so perhaps it's a caution to us to take a step back and actually appreciate the benefit of adequate staging of patients before any intervention, whether it's surgery, whether it's chemotherapy. And again, embracing the concept of a multidisciplinary team approach to care, discussing with colleagues about what are the benefits of chemotherapy, systemic therapy, and any other additional therapies that would help to give a total holistic plan for our patients. This, of course, we're not necessarily talking about palliative local regional control. And this is for patients who are having disease progression. Sometimes we see a large fungating tumor, and most surgeons would say, you want to go and cut it out. But we've also seen dramatic responses in patients who've actually had systemic therapy despite large tumors, pretty dramatic. But one would say, of course, in the setting of disease progression, despite these systemic therapies, there's definitely a role for what we're doing a toilet mastectomy. And again, one also has to think about, what am I going to do in terms of margins? If I'm going to cut it out and I'm going to leave tumor behind, then one does sort of think about, is this actually worth it? And of course, if you're going to cut out a large area and you have to think about complex reconstructive, like, basic LD flap to sort of cover the defect, then one also has to sort of put those into consideration, especially, and also look at through the lens of the balance of what is the quality of life of the patient versus the cost of care, and financial burden to the patient. Again, we haven't really touched on oligometastases, which, as we know, are a separate category where we're defined as operable primary tumor and 4 less sites of metastases. And of course, with the advances in both surgery and systemic therapies, where one can say we're potentially able to tip these patients to, no evidence of disease status, or perhaps even cure, we don't know. But the whole idea is this is on a case-to-case basis and should definitely, I would say in conclusion, there is a limited role for surgery in metastatic breast cancer, but this should always be weighed in the context of a multidisciplinary team decision, and that should definitely be considered in patients who are having disease progression. Thank you.